Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Today is our cardiac surgery weekly academic activity. Me and Dr. Hassan Sharia will moderate this week. We have 3 lectures. The first lecture is about the pathophysiology and diagnosis of the aortic dissection, presented by Dr. Isa Swab. And the next lecture will be about trauma to the great vessels, presented by Dr. Salim Tawfiq. And the third lecture will be about the pulmonary embolism and thromboendarterectomy, presented by Dr. Zayed Sharif. So, Dr. Isa, if you are ready, you can start your presentation.
Assalamu alaikum. I'm ready. I will share just the screen. Can you see the screen?
Yes, you can start.
Okay. Good afternoon, everyone. Today, my speech will be about the pathophysiology and diagnosis of aortic dissection. Thoracic aortic dissections occurs when an intimal tear allows redirection of blood flow from the aorta to the lumen through the intimal defect into the media of the aortic wall, false lumen. A dissection plane that separates the intima from the overlying adventitious forms within the media, and the acute form of the aortic dissection is often rapidly lethal. Dissection occurs nearly 3 times as frequently as rupture of abdominal aortic aneurysm, and there is an estimated worldwide prevalence of 0.5 to 2.95 per 100% per year. So the classification system used for aortic dissections are based on the location and extent of the dissection, and the particular type is then subclassified based on time dissection, whether acute dissection or chronic dissection or subacute dissection. The acute dissection presentation within the first 2 weeks, and chronic presented at more than 3 months after the initial event, and subacute the period between the 2 weeks and the 2 months. As we see here, the classification of the aortic dissection. We have 2 classifications for the aortic dissection. We have the DeBakey classification and Stanford classification. In the DeBakey classification, type 1 involves the ascending aorta and arch, and ascending thoracic aorta, and may progress to involve the abdominal aorta. Type 2 is confined to the ascending aorta, and type 3A involves the descending thoracic aorta, distal to the left subclavian artery and proximal to the celiac artery. And type 3B, its dissection involves the thoracic abdominal aorta, distal to the left subclavian, distal to the subclavian artery, and distal to the celiac artery, and may progress to distal to the celiac artery. And in Stanford classification, we have 2 types, type A and type B. That's what is usually we use in our practice. Type A, it involves the ascending aorta and may progress to involve the arch and thoracoabdominal aorta. And type B involves the descending thoracic or thoracoabdominal aorta distal to the left subclavian artery without involvement the ascending or aorta or arch. So the etiology and pathogenesis, several hypotheses exist regarding the etiology of the intimal disruption primary tear that permits aortic blood flow to create a cleavage plane with the media of the aortic wall. As a consequence of biochemical abnormality within the media on which normal mechanical forces on the aorta acted to create an intimal tear, termed cystic medial necrosis or degeneration. Medial degeneration is found in only a minority of patients with acute aortic dissection. There are data supporting a relationship between aortic dissection and intramural hematoma as a result of bleeding from vasoram into the media creates a mass that results in localized areas of increased stress in the intima during diastole. Penetrating atherosclerotic ulcers have been implicated as the source of intimal disruption in some cases. Several risk factors have been identified that can damage the aortic wall and lead to dissection. The most common two, the direct mechanical force of the aortic wall, and most common cause is the hypertension, and the forces that affect the composition of the aortic wall with the connective tissues diseases. The direct mechanical forces in aortic wall hypertension, like in hypertension, is the mechanical force most often associated with dissection and is found in greater than 75% of the cases. Forces that affect the composition of the aortic wall, like in its connective tissues disease, the media is composed of concentrically arranged smooth muscle interposed with the connective tissues proteins, such as collagen, elastin, and fibrillin within the ground substance. Like Marfan syndromes is an autosomal dominant inherited disorder in which a point mutation in fibrin 1 gene located in the long arm of chromosome 15 result in abnormal media. And type 4 Ehlers-Danlos syndrome is a connective tissues disorder of a pro-alpha-1 3 chain of type 3 collagen. Risk factor for type A and type B thoracic aortic dissection are the hypertension, connective tissues disorders like Ehlers-Danlos and Marfan's and Turner syndromes, cystic medial disorder of aorta, aortitis, heterogenic, and atherosclerosis, thoracic aortic aneurysm, bypass aortic valve, trauma, pharmacological, coarctation of the aorta, hypervolemia like in pregnancy, congenital aortic stenosis, polycystic kidney disease, pheochromocytoma, Sheehan syndromes, and Cushing syndromes. Once a cleavage plane exists in the media, the aorta wall floating within the lumen is termed the dissection flap and is composed of aortic intimal and partial thickness media. The primary tear in type A dissection is usually located in the right anterior aspect of the ascending aorta and spiraling around the arch and into the descending thoracic and abdominal aorta on the left and posteriorly. So the dissection may propagate in retrograde fashion for a very variable distance as well to involve the coronary ostia. Myocardial ischemia or aortic rupture into the pericardium is the cause of the death in 80% of mortality. Often the distal false lumen communicates with the true lumen through one or more fenestrations within the dissection flap. The false lumen may also end blindly in as many as 4 to 12% of patients, in which case a false lumen frequently thrombosed. It may also penetrate the adventitia, causing rupture and death, and perfusion of the aortic side. Branches may be compromised by the dissection, resulting in end organ ischemia. The outer aortic wall composed of partial media, and the adventitia may dilate, resulting in aneurysm dilatation. As you see here, there's the pictures of true lumen and false lumen. Clinical presentation, aortic dissection should always be considered in the setting of severe chest pain, which is characterized by ripping or tearing, and tachycardia, is usually combined by hypertension, and tachycardia may result from aortic rupture, pericardial tamponade, acute aortic valve regurgitation, or even acute myocardial ischemia within the involvement of coronary ostia. And abnormal peripheral vascular presence of diastolic murmur consistent with acute aortic regurgitation or S3 indication left heart volume overload. Jugular venous distension or abulsus paradoxus are signs of pericardial tamponade. Unilateral loss of breath sounds, usually in the left sides, indicate hemothorax as a result of aortic leak or rupture. Involvement of the brachiocephalic vessels with loss of brain perfusion may result in transient syncope or stroke, or they might lead to coma. Loss of perfusion to intercostal or lumbar artery may result in spinal cord ischemia or paraplegia. Malperfusion of aortic branches vessels may occur from the coronary ostia to the aortic bifurcation. Compression of the true lumen by the false lumen is the mechanism by which aortic branch vessels occlusion occurs in the majority of the cases, and branch vessels may also be completely sheared off the true lumen and perfused to various degrees by the false lumen. As you see, the frequency and location of malperfusion in acute type A and B thoracic aortic dissection renal 23 to 75%. Extremities, upper or lower, 25 to 60%, and mesenteric 10 to 20%, and coronary 5 to 11%, cerebral 3 to 13%, and spinal 2 to 9%. So, diagnostic imaging to diagnose the aortic dissection, two imaging modalities currently are used to diagnose acute aortic dissection are the computed CT tomography, the CT or echocardiography, transthoracic or transesophageal. MRI and aortography, intravascular ultrasound, IVUS. The IVUS are used to diagnose acute aortic dissection, but are second-line modalities. So, the sensitivity and specificity of various imaging modalities useful for the diagnosis of thoracic aortic dissection. The aortography, the sensitivity is ranging from 80 to 90%, and specificity, it's 88 to 93. The CT, the sensitivity ranging from 90 to 100%, and specificity also ranging from 90 to 100. The IVUS, ranging from 94 to 100, the sensitivity, and specificity 97 to 100. Echocardiography, the transthoracic 68 to 80, the sensitivity and specificity 80 to 96, and the transesophageal 90 to 99, the sensitivity and specificity it's 85 to 98. MRI, it's ranging from 98 to 100, and the sensitivity and specificity 98 to 100. So the CT, it's the widely available and is now the most frequently used test to diagnose the aortic dissection. And these techniques can be performed quickly for operative planning, and CT scan with arterial phase contrast of the chest, abdomen, pelvis to the level of the femoral artery is ideal. As we see in these pictures, we see here the false lumen and the aorta, the true lumen. The transesophageal echocardiography is currently the second most frequently used study for making the diagnosis of acute aortic dissection. It is best performed in OR under general anesthesia, and it's operator dependent. A criteria for making the diagnosis of acute aortic dissection, including visualization of an echogenic surface separating two distinct lumen. The true lumen is identified by expansion during systole and collapse during diastole. Communication of false lumen is found by identifying distal tears in the flaps and flow in the false lumen with addition with color Doppler. TE provides high quality images of aortic valve and pericardial space. As we see in these pictures, we see the aortic valve flaps here, and as also in the other in the right image, also we see the flaps here and the aortic outlet. So aortography, it was considered the gold standard for diagnosis. And it's an invasive test requiring contrast media in which the aorta is visualized in multiple two-dimensional projections. The diagnosis of dissection depends on visualization of the intimal flap. Aortography can have a high false negative rate secondary to thrombosis. One major limitation to the use of aortography in the acute setting is the need for skilled person, like in the TE. The IVUS, it is a catheter-based imaging tool that provide dynamic imaging of the aortic wall and an intimal flap in patient with aortic dissection. And it's particularly useful in delineating the proximal and distal extent of dissection and for identifying the true and false lumen in questionable cases during aortography. It is time consuming and requires skilled personnel. MRI and MRA generate superior images and reliably demonstrating aortic dissection. MRI and MRA offers the detailed anatomy as CT does, but does not require radiation. MRI may be particularly useful in to diagnose a pregnant patient. As we see here in these images, like here, it's distal to the subclavian, the false lumen, and in the other images, we see the false lumens. And that's the end of my presentation. Thank you for listening. Any question?
Thank you, Dr. Isa, for your excellent presentation. The floor is open for any question for Dr. Isa. Okay, we'll take a break for 10 minutes, then we'll continue for the next lecture. Good afternoon. The next lecture will be about the trauma to the great vessels presented by Dr. Salim. Dr. Salim, if you really can share your presentation and start.
Assalamu alaikum.
Walaikum assalam.
My name is Salim Tawfiq, and today I will present trauma to the great vessels. I will start with my objective. I will talk first for statistic and then how to approach a trauma patient, then how to classify traumatic aortic injury. Then I will talk about ascending aortic trauma, aortic arch branch, vessels trauma, then the descending aorta trauma. Blunt thoracic aortic injury is the most common thoracic vascular injury. 75 to 90% of the cases will die the accident scene, 4% will die during the transfer, and 19% will die during the initial trauma assessment. In hospital, mortality of patient managed non-operatively 46. 9% mortality when you treat the patient by endovascular, 19 with open repair. Aortic transection at the isthmus is the most common site of injury, followed by the base of the innominate artery, then by the left subclavian artery. Central venous structure are rarely injured with the blunt trauma, but may be accurate with the penetrating trauma. How we approach a trauma patient, we will start with the ATLS protocol. Primary survey will protect airway, C-spine protection, breathing and ventilation, oxygenation, and we will look for circulation, we stop the bleeding, external bleeding, and we look for other source of internal bleeding, and we will see the disability and neurological, and we'll assess the neurological status, and we'll expose and we cover the patient. Adjunct to the primary survey, we will see the vital sign, ABG, pulse oximetry, urine catheter and urine output, ECG, chest and abdomen, pelvic X-ray, and we'll do fast. Secondary survey will look for ample history and head-to-toe examination. There is a clue suggest aortic disruption. We start with the history: motor vehicle crash, speed more than 50 km/h, motor vehicle crash into fixed barrier, no seatbelt, ejection from the car, motorcycle or airplane crash, pedestrian hit by motor vehicle, fall greater than 3 meters. By the physical sign, we look for if the patient hemodynamic shock, systolic blood pressure less than 90, fracture of the sternum, first rib, clavicle, scapula or multiple rib, cardiac murmur, dyspnea, back pain, hemothorax, paraplegia or paresis. The chest X-ray will show the widening of the mediastinum. There is right deviation of the nasogastric tube, trachea shifted to the patient right. There is pulmonary contusion, clavicle fracture, thoracic spinal fracture. After the patient, after stabilization the patient, we can do CT. CT is the screening tool of choice of the trauma patient. We'll do CT with contrast for the abdominopelvic and forehead also, and that will show all great vessels. Transesophageal echocardiography. This we use the echo for imaging the entire descending and portion of the ascending aorta in an unstable patient or a patient in the OR. MRI, vascular structure will image by MRI, but not at the emergency setting, we cannot do the MRI. Aortography is when the CT or TE fail to identify aortic injury, and aortography is the gold standard because it's for diagnosis and intervention. Classification system for traumatic aortic injury: grade 1, only intimal tear or flap; grade 2, intramural hematoma; grade 3, pseudoaneurysm; grade 4 is a rupture. Decision to repair versus expectant management. Hemodynamic and stable patient should bypass all diagnostic imaging and to be taken to the operating room immediately. During the damage control, exploratory laparotomy or thoracotomy TE may be conducted to diagnose aortic rupture. But the operative repair of the aortic should not be attempted at this time. We should transfer the patient to the ICU, and after hemodynamic stability, we'll start anti-impulsive therapy with beta blocker to minimize the aortic wall stress. Treatment of all non-life-threatening injury should be delayed until definitive aortic repair. Now I will start with the first, the ascending aorta. Mechanism of the injury: transmission of the force through the thoracic cavity from blunt injury cause a torsion of the ascending aorta, leading to disruption of the wall with the associated shear effect on the heart, cause pseudoaneurysm formation. Endovascular intervention for the ascending aorta, because the proximity of the aortic valve and coronary artery, the ascending aorta, you will not, the intervention is only open, is not for endovascular. The operative repair of the ascending aorta, pseudoaneurysm of the ascending aorta should be repaired using cardiopulmonary bypass, femoral or axillary femoral cannulation, and starting cardiopulmonary bypass before median sternotomy may decompress the ascending aorta and decrease the risk of pseudoaneurysm rupture. After entering the pericardium, the pseudoaneurysm should be carefully mobilized, if possible, to gain paroxysmal and distal control. Depending on the natural and extent of the injury, repair may be conducted or by primary repair or by patch angioplasty or prosthetic replacement. If there is aortic valve insufficiency, we'll replace the valve. And innominate artery, the innominate artery is the second most common site of thoracic vascular injury. 83 in the proximal vessels, 3% in the medial, 9% in the distal. The most common find was disruption of the intima and media with pseudoaneurysm formation. The pathogenesis of blunt innominate artery rupture results from anterior-posterior compression of the mediastinum between the sternum and vertebra, displacing the heart posteriorly and to the left, and that will increase the curvature of the aortic arch and increase the tension and will lead to the rupture. Hyperextension of the cervical spine with hydrotation provide additional tension on the right carotid artery, then transmitted to the innominate and will lead also to innominate artery injury. Endovascular of the innominate artery, stable patient with a blunt pancreatic injury to the innominate artery have beneficial from endovascular repair. That there is a technical consideration when the innominate artery for the distal landing zone, if the stent will occluding the carotid artery or not. Primary repair of innominate artery possible in some cases with the surgical repair. they will do aorto innominate bypass graft from the aortic arch. As necessary. Operative repair of the pancreatic innominate artery is approached with the same manner. The entire length of the innominate artery should be mobilized to achieve distal control and the pericardium open to gain proximal control. After systematic administration of heparin, partial occlusion clamp is applied to the aortic arch and the proximal anastomosis of the prosthetic graft performed into site anastomosis, or a Y graft may be required if proximal portion of the right carotid and left and right subclavian artery individually. Healthy patient will tolerate the partial temporary occlusion of the innominate artery. Long-term patency of the prosthetic innominate artery bypass graft has been reported to be greater than 96% at 10 years. Left carotid artery. The left carotid artery undergoes stretching injury with the rapid deceleration, producing an intimal tear and subsequent dissection. Additional mechanism of carotid artery include hyperflexion of the neck to cause compression between the mandible and cervical spine. Endovascular intervention of the carotid trauma to the intrathoracic carotid artery is rare, but case of successful stenting exclusion of the pseudoaneurysm have been reported. Embolic risk should be considered when assessing where the lesion is suitable for endovascular or no. Safely anticoagulation, even with the patient with intracranial or solid organ injury, can be done with the partial BTT between 40 to 50 seconds. Open repair of blunt carotid artery injury must be directed to prevent cerebral ischemia, and surgical intervention should be weighed against the observation and anticoagulation. Small intimal flap may be resolved. Large flaps can lead to thrombosis and therefore require anticoagulation to prevent thromboembolism. Arterial dissection may progress to luminal narrowing, placing the patient at high risk for thrombosis, and anticoagulation therapy is especially important in patients with bilateral carotid artery dissection. Median sternotomy with extension along with the anterior border of the ipsilateral sternocleidomastoid muscle as necessary to gain adequate exposure. After gaining proximal and distal control, arterial repair may be accomplished by primary repair or interposition graft with saphenous vein. Subclavian artery, blunt subclavian artery injury are common in the middle and distal third of the artery, caused by down force of fracture of the first rib with the anterior scaling out as a fulcrum to so that the subclavian artery is pinched between the first rib and the clavicle. Injury to the subclavian artery from blunt or penetrating trauma carries mortality rate of 5 to 30%, result from inability to obtain adequate hemorrhage control through the direct pressure. Endovascular repair of subclavian artery has been relatively well described in the literature because of the obvious benefit of this procedure compared with the morbidity of open subclavian artery exposure. Stent grafts have effectively treated pseudoaneurysm, laceration, and complete transection of the subclavian artery, reducing the incidence of brachial plexus injury since the dissection of the traumatized field has been eliminated. Stent graft repair of the subclavian artery may cover an internal thoracic artery that has been used as a pedicle graft for coronary artery bypass graft, placing the patient at risk for significant cardiac ischemia. Operative repair of subclavian artery, because the close proximity of the trachea and esophagus, subclavian vein, brachial plexus, subclavian artery injury are associated with 40% morbidity. Operative exposure may be achieved by median sternotomy, limited sternotomy, supraclavical incision, or infraclavical incision. Once established proximal and distal control of the subclavian artery, the damaged arterial segment may be excised and the arterial reconstruction accomplished with using a saphenous vein or prosthetic material. The descending aorta, thoracic aorta, this is the most common site of injury. The rupture will occur at the site of the isthmus because it's free. The descending aorta is freely is not attached except at the site of the isthmus. So when there is a descending deceleration, that will do a stress to the stress rupture at the site of the aorta at the isthmus. In trauma patient with blunt aortic injury, the endovascular was initially applied to patients considered extremely high risk for open repair, like those with head injury, abdominal vascular injury, or severe pulmonary contusion. Now, the endovascular repair is the technique that's used for treating the descending aorta injury. Open repair of descending aorta, clamp and sew technique. You will clamp distal and proximal to the injury and will do the anastomosis. That will carry 10% risk of paraplegia. There is other technique with partial left heart bypass. We'll do cannula in the inferior pulmonary vein and the other cannula distal to the injury, and then you will put clamp and you will do the repair. This is my reference, and if you have any question.
Thank you, Dr. Salim, for your presentation. But I would like to note a few presentation come with more image and radiography will be more clear for our to understand. But thank you, and I would like for the next presenter to be more active in the lectures. Any question for Dr. Salim? Okay, thank you. We'll take a quick break for 5 minutes, then we'll start with the third lectures. Thank you. Good afternoon. We'll continue with the third lectures about the pulmonary embolism and thromboendarterectomy presented by Dr. Ziad Sharif. Dr. Ziad, if you're ready, you can start.
Okay, thank you, Dr. Assalamu alaikum jami'an. My name is Ziad Sharif, and today I will present you pulmonary embolism and thromboendarterectomy. These are our objective. I will start with introduction, then I will talk about prevalence, then explain the basic pathophysiology and list the current risk factor of BE. Then I will describe clinical presentation and explain diagnostic evaluation. After that, I will explain current treatment of BE. Finally, I will talk about pulmonary thromboendarterectomy. Pulmonary embolism occurs when a thrombus in another region of the body embolize to the pulmonary vascular tree and blood flow distal to the embolus is obstructed. Massive type result in acute right ventricular failure and death typically within 2 hours, usually undiscovered until autopsy. It is estimated that 95% of pulmonary embolism arise from source and it is complication of DVT. Source of the emboli can be from deep venous thrombosis or other veins such as superficial femoral vein. In deep venous thrombosis, lower extremity is most common, while the upper extremities is very rare. Other sources of emboli include fat, amniotic fluid, air, or septic embolus in IV drug abuser. Pulmonary embolism causes over 100,000 deaths each year, and about 10% of DVTs are associated with pulmonary embolism. Of these, about 10% are fatal. Pathophysiology can be identified as blocking a portion of pulmonary vasculature, leading to increase in pulmonary vascular resistance and pulmonary artery pressure, which increase in the right ventricle pressure, and also the decrease in the filling of the left ventricle causes decrease in the cardiac output, and hypoxemia will stimulate vasoconstriction and increase in the pulmonary artery pressure. Decreased blood flow in some area of the lung leading to hyperventilation and creating dead space in the lung. There is a lot of risk factors, include DVT, history of DVT or BE, and other factors. Most patients who present with pulmonary embolism will have one of these risk factors. As the number of the risk increases, the risk also increases. Signs and symptoms will differ within the degree of pulmonary vascular occlusion, and most often it is clinically silent. Larger the embolus, the greater the clinical signs and symptoms. Symptoms include dyspnea, which is most common, pleuritic chest pain, cough, hemoptysis, unilateral leg pain from DVT, and other symptoms. Signs include tachypnea, tachycardia, diaphoresis, lower extremity edema, cyanosis, and other signs. Most sensitive symptoms are tachypnea and tachycardia. 95% will have at least one of the following: dyspnea, tachycardia, or pleuritic chest pain. If these findings are absent and the patient is without risk factors, the diagnosis of pulmonary embolism is unlikely. In the diagnosis, you start by history and physical examination, then to initial tests like chest X-ray. It's usually normal and used to exclude alternative diagnosis. In ABG, will show low pressure O2 and CO2 and respiratory alkalosis. In ECG, will show sinus tachycardia, anterior T-wave inversion, and ST segment and T-wave changes, and rarely right bundle branch block. Then the confirmation test, which divide into two. With high clinical suspicion, first we have CT angiogram. It will visualize pulmonary vessels, allow us to see the clots. If the clots present, it's confirmed BE and is contraindicated in renal failure patient. It's considered non-invasive test with high degree of sensitivity and specificity, and has 99 to 100% negative predictive value. Second, we have VQ scan, usually used when CT angiogram contraindicated. If normal, then exclude BE. If show high probability, then it will confirm BE. If low or intermediate probability, do lower extremity duplex ultrasound. Third test. And third test is lower extremity Doppler ultrasound. It is used when FAQ scan show low or intermediate probability. Last one is pulmonary angiogram, and it is used when all above are equifocal. If low clinical suspicion, we will do D-dimer. If positive, start steps for high clinical suspicion. If negative, we will exclude BE. In the diagnosis, the gold standard is pulmonary angiography, but not available at all institutions, and it is invasive with associated risk and complication. In MI and pneumonia and congestive heart failure patient, the dimer will be elevated. In the treatment, you should begin with ABCs with close monitoring, then start oxygen and fluids as patient may have signs of hypoxia and advance to state of shock. Anticoagulation with the use of heparin has been the mainstay of treatment. Heparin bolus should be given, followed by continuous IV. Any contraindication should be addressed. The use of thrombolytic in BER going increase in use, usually only in an unstable patient or right side heart failure. Clinical trials are still being done for the use of thrombolytic in BE. Other options such as IVC filter in patient contraindicated to anticoagulant or recurrent attack on the use of anticoagulant or right side heart failure can be done. Embolectomy can be done to remove life-threatening BE in an unstable patient. To the second part of our lecture, which is thrombondartectomy, it is a surgery to remove blood clot and scar tissue from the arteries of the lung. It's called pulmonary thrombondartectomy or PTE, and it's also called pulmonary endarterectomy or BEA. And it's considered therapy for chronic thromboembolic pulmonary hypertension. The true incidence of chronic thromboembolic pulmonary hypertension is unknown. However, most experts agree that approximately 4 to 5% of all patients who have an acute episode of pulmonary embolism. The disease characterized by intraluminal thrombus organization, fibrotic scar tissue like stenosis. For surgical technique, there is 4 basic principles. First, endarterectomy must be bilateral. Second, perfect visualization is essential. Third, identification of correct dissection plane is crucial. Fourth, a complete endarterectomy is essential. To the step, we will start by median sternotomy, then pericardium is incised. After that, cardiopulmonary bypass with high ascending aortic cannulation and 2 Keffel cannula. Then pulmonary artery vent in the midline of main pulmonary artery. The patient is cooled to 20 degrees Celsius. In this picture, you can note that initially the surgeon stands on the left side of the patient. The left atrial vent is placed in the right superior pulmonary artery and directed into the left ventricle while the patient is cooling and the heart fibrillating. Initially, primary surgeon to stand on the patient left side and perform on the right side. The approach to the right pulmonary artery is made medial to the superior vena cava. Once the core temperature has reached 20 degrees, an aortic cross clamp is applied and myocardial protection is provided. In this picture, you can see surgical approach to the right pulmonary artery. And please note that the right pulmonary artery is approached between aorta and superior vena cava, not lateral to the superior vena cava. A modified tubular retractor is then used to expose pulmonary artery. Incision is made in the center of the right pulmonary artery from beneath the ascending aorta, out under the superior vena cava, and entering the lower lobe branch of pulmonary artery, just after takeoff of medial lobe of artery. Any loose thrombus, if present, is now removed. Once circulatory arrest is initiated, the correct plane appears barely white, smooth, silky in appearance, lies between intima and media. It's rare for this to exceed more than 20 minutes for each side. In this picture, you can see that the plane dissection is raised posteriorly initially, and then a complete endarterectomy is performed. The endarterectomy is then performed with an inversion technique because the vessel is everted and subsegmental branch are being worked on. It's important that each subsegmental branch is followed and freed individually until the ends. Once the right side is completed, circulation is restarted and the arteriotomy is repaired. Then the surgeon moves to the patient right side. A left pulmonary arteriotomy is made, slightly lateral to the pulmonary vent site and extended to the precardial reflection. Care must be taken to avoid injury to the left phrenic vein. The heart is wrapped within a cooling jacket and retract using mesh-like basket retractor shown in figure 4. In this picture, you can see the surgical approach to the left pulmonary artery. The heart is retracted medially using a net-like retractor and left pulmonary artery is exposed. The left side dissected is vertically analogous in all aspects to that accomplished on the right side. After completion of the endarterectomy, cardiopulmonary bypass is reinstituted and warming is commenced. If other cardiac procedures are required, such as coronary artery or mitral aortic valve surgery, these can be performed during systemic rewarming period. The most common procedure is closure of foramen of valve followed by coronary bypass. When patient fully rewarmed, cardiopulmonary bypass is discontinued with a successful endarterectomy. Surgical classification, there is 4 levels for occlusive disease. Level 0, no surgical evidence from thromboembolic disease. Level 1 indicated that obstruction involved one of the main pulmonary artery. Level 2, the fibrous tissue start at the level of lobar branch. Level 3, the disease distal to the start and segmental branch. Level 4, the disease starting at subsegmental level only, and this represents the most challenging patient. In this picture, you can see the surgical classification. Outcomes. In majority patient after successful surgery, post-operative hemodynamic values become normal or near normal. Although most patients enjoy a significantly improved hemodynamic state and improved functional class, residual pH after surgery remain the most important causes of early post-operative morbidity and mortality. In conclusion, surgical removal of thromboembolic material by endarterectomy provide an opportunity to relief from this fatal disease. Although PTE is technically demanding for the surgeon and requiring careful dissection, excellent short and long-term result can be achieved. Technical advances of the procedure have significantly improved the outcomes, and the newly designed instrument allow better visualization and more complete endarterectomy in the distal segment and distal segmental and subsegmental branch. Educating physicians and training surgeons to master the technique should remain the priority of the treatment in this disease. In this picture, you can see of some instruments used during pulmonary endarterectomy. These are my resources. Thanks for listening. If you have any question, please.
Thank you, Dr. Ziad. Any question from the audience? So we can conclude our weekly academic activity this week. Thank you for everybody, presenter and audience.